here? All right, can I get another aloha? My name is Rachel Secretario. I'll be your MC today. We're gonna have a lot of fun today, super fun. Thank you so much for coming out to support the Kauai Rural Health Association, Ola Pono o Kauai Conference Program, and for our conference speakers. Thank you so much. Thank you for being here, everyone. Our first speaker today is Leo Sandoval from our mayor's office. Leo Sandoval is the Director of Liquor Control for the County of Kauai. Prior to serving as the Liquor Director, he served as a state police officer and supervisor for 10 years, overseeing the Alcohol Enforcement Division of Texas Alcoholic Beverage Commission in Dallas-Fort Worth Metroplex, where he handled cases ranging from liquor violations, human trafficking, and various organized crimes. Director Sandoval is a graduate of Lubbock Christian University, where he earned a master's degree in organizational leadership and a bachelor's degree in social work. Let's give a big round of applause for Mr. Leo Sandoval.
All right. Hello, everyone, and thank you for having me here today. I'm going to be speaking today on behalf of Mayor Derek Kawakami that was unable to be here in person today, so I'm here. Hopefully you guys enjoy. Try not to keep it too long, too winded. First of all, we want to give a big mahalo to all those involved in coordinating today's Ola Pono o Kauai event for Mental Health and Awareness Conference. I'm so happy to see so many people that are involved in this kind of organization and actually interested in getting the awareness and additional training for this type of topic. It is very needed on the island and everywhere else. Mahalo to the Office of the Prosecuting Attorney, Prosecutor Becky Lique, there she is, right there. And our Life Choices Kauai Program Coordinator, Michael Miranda, which I saw him somewhere today too. Thank you, Michael. Along with the Hawaii Department of Health, the Kauai Rural Health Association, Kauai Planning and Action Alliance, the Kauai Resilience Project, and the Keiki to Career. And of course, the attendees and participants here today, your dedication to supporting mental health and services and the well-being of our community is vital to helping our island, and not just to heal, but to thrive on our island as well. Sorry, I made a lot of notes down here, and I didn't realize the podium's going to be so low down here. So, last month was Mental Health Awareness Month, where we acknowledge mental health as an important public health issue that should be discussed with youth, adults, and family in our communities. As well as moving beyond the term awareness, we can redefine how we address mental health to foster acceptance and end the prejudice and discrimination. Acceptance demands we advocate and act to change attitudes, behaviors, and systems. Some of the statistics that came up were, 1 in 5 youth have a mental, emotional, developmental, or some sort of behavioral disorder. 1 in 5 adults live with a mental illness. And then we have 1 in 5 adults over 55 years old experiencing some type of mental health concern. After looking at the statistics, I can relate to some of those statistics. As probably all of you can. We've all had or have known of a family member that have had some kind of crisis or some kind of need for assistance from a mental health professional. Coming from my background, is a Hispanic background. And a lot of the times whenever we start having these kind of issues in my culture, they kind of tuck it away. It's kind of like a not talked about kind of situation. Something's there, but we really don't talk to somebody about it. But that's something that needs to change. Having that conversation within the ones that I've known in my family, to let them identify that, I know you've heard the term, being not okay is okay. You're not always going to be okay. But you have to realize and recognize when is the time to actually ask for help. And fortunately, that's something that's being broken. those chains are being broken down, and now people are being aware, that it's okay to ask you guys. There are people that understand what you're going through. It's time to break down that stigma that it's not okay, So the future well-being in our state also truly depends on our acceptance of people with mental health challenges and how we support and ensure access to resources when they need help. We've truly been blessed with individuals that are willing to step up to these challenges as you are. As you heard also in my bio, my background is also in social work. Now, the reason I went into getting that degree as well is because it's not only helped me in understanding human behavior and where to receive the resources for people that need those kind of resources, it's helped me also to identify when people are not okay. I've had the background of being a police officer. In the past 10 years when I was working for the state police, most of the activities, if you're not aware of mental health issues and someone is committing a crime, you sometimes have to differentiate, is this person having a crisis or are they actually doing something that they're not knowing about, You have to know when to step in and say, hey, maybe they need this mental health professional to help them with this crime. It's not always, they may sometimes not be in their right mind and just need that extra assistance. And that's where you guys are stepping in. Now, throughout the next 2 days, as you hear from industry leaders and officials, you're helping Kauai and Hawaii take another step forward with supporting these significant healthcare needs. And by investing your time and passion here, you're helping to keep the community healthy and safe. I can guarantee it takes a special person to do the job that you're wanting to do. Not everybody wants to do it, but you guys are resilient in knowing what you want to do and how you want to help everybody. And I applaud you for that because you truly are a genuine kind of person. For that, we thank you for being here, dedicating your time and service to our youth, adults, families, and all of Kauai as we work to overcome the challenges and barriers of mental health treatment here on this island, or on our island. Talking about mental health destigmatizes people's view of it and increases the likelihood those who are struggling will seek help. So don't make it a taboo issue. If somebody asks somebody for help, don't make them think that there's something wrong with them. Tell them that there's something that we can help you with. Is there something I can do for you to help you doing what you're doing? So being here, you guys have taken the first step. Let's continue talking about all these issues. That's what makes it easier, having an open dialogue. And for that, that's what I have for you guys. I appreciate you guys for being here. I hope the rest of the conference here today will be of benefit to you and that you also will learn a lot, network a lot, and put into practice what you learned during this conference. So, mahalo and aloha.
Thank you again. Let's give him a big round of applause. Thank you so much for coming down. And thank you to you guys again. Thank you for break down that, to echo what you're saying, Leo, Sandoval, thank you so much for being here, representing the mayor's office. It's so important to break down that stigma, and thank you for starting the conversation. Again, as he kicked the projector here, if you can notice the thank you to the Boys and Girls Club for giving us this beautiful screen here, but it is a little bit smaller, so if you do need slides, we will be happy to email them to you, so we can have all access to all of the slides today. Okay, I'd like to bring up our next amazing speaker, Rebecca Leake, for crime and mental health. There is a higher percentage of incarcerated people with mental illnesses that are in the general population. Treating these individuals and preventing them from reoffending requires the use of innovative, evidence-based practices. Rebecca Leake is the prosecuting attorney for the County of Kauai. Prior to serving as the prosecuting attorney, she worked as a deputy prosecuting attorney handling a variety of offenses, from traffic offenses to murder cases. She received her law degree from Northwestern School of Law at Lewis and Clark College in 2009. Let's give a big round of applause for the amazing Rebecca Like. Thank you for joining us.
Good morning, everyone. Okay, let me just get set up here. Is there any way you can move it back a little bit so I can see where I'm at? Okay, fabulous. I'm so excited to be here. I'm thrilled to be able to see everybody in person, and I just wanted to first say thank you to you all for being here. One thing I talk a lot about is access to resources, and I feel like one of the main resources we have on Kauai are you folks, all you folks who really care about helping people. So today I'm going to talk a little bit about mental health and crime. I think most of us are aware of the issue that folks who are incarcerated have a higher percentage of, are more likely to have mental health issues, and I'm going to talk a little bit about different intervention points in the system and evidence-based programs that have been implemented throughout the country that have been effective at treating folks with those issues. And I want to start out too by saying that mental health is something that's really personal to me. Following the birth of my first child, I struggled with pretty severe postpartum depression, and it was really difficult for me to find a therapist here on Kauai. And I feel like I'm a pretty resilient, well-resourced person, and so I know that folks who are less well-resourced and connected are going to have more issues finding access to those mental health resources than I myself did. So I just wanted to mention that. And I want to talk, in my presentation, there's a lot of overlap between mental health, trauma, and substance use disorder. So those things are all really intertwined. That's why my first picture is of that knot, it's hard to kind of untangle that knot. But as I mentioned, there's a disproportionate number of incarcerated folks with mental health issues. Close to half of all inmates have been diagnosed with a mental disorder, and 44% of those in jail and 37% of those in prison, compared to about 18% in the general population. More than half of inmates have a substance use disorder, 63% of those in jail and 58% of those in prison. An estimated 2 million of the 11 million annual jail admissions involve a person with a serious mental illness, and almost half of those individuals also have a co-occurring substance use disorder. Half of inmates in state prisons who have a history of substance use disorder also have a history of one or more mental health conditions, compared to 38% of US adults. And prevalence of every single mental health condition is higher for incarcerated women. Rates of PTSD, rates of manic depression, bipolar disorder, and depressive disorders are double the rate compared to men. Mental health diagnoses in state prisons are more prevalent among multiracial people than white people, Native people, Hispanic, Black, or Asian people. And these figures also track closely with how people of different racial and ethnic groups utilize mental services outside of prison. And incarceration and the programming of incarceration can exacerbate existing mental health conditions. So it's not surprising that individuals with mental health diagnoses can spend longer terms in prison and jail. And government spends 2 to 3 times as much on incarcerating mentally ill individuals, and the programs are often not evidence-based that they receive while incarcerated. So I'm going to talk today about the sequential intercept model, which was developed by SAMHSA, or the Substance Abuse and Mental Health Services Administration, which is an agency within the U.S. Department of Health and Human Services that leads public health efforts to advance the behavioral health of the nation and improve the lives of individuals with mental and substance use disorders and their families. So SAMHSA has identified various criminal justice intervention points in their, I'm going to call it SIM, the sequential intercept model, to help improve the lives of individuals living with mental health and substance use disorders. So at each intervention point, there's steps that are taken to address the mental health issues. So first is identifying successful and promising evidence-based programs. Second is introduce ideas for possible programs on Kauai and steps we are taking to implement and support certain approaches. These examples were taken from a compendium published by the Fair and Just Prosecution. And here's the flow chart of how a person would work their way through the criminal justice system with each intervention or interception point as a row in the flow chart. At each point, we identify the people in the system who have behavioral health disorders who would benefit from services, provide those services, work with treatment providers to link to appropriate services, as well as work within the justice system to provide appropriate level and type of substance use and or mental disorder treatment, advance continuum of care practices, and monitor progress with benchmarks to adjust for the level of care. There's characteristics for each intervention. They should be designed by clinicians to incorporate up-to-date research and best practices. Prevention and early stage intervention should be prioritized. Individuals with lived experience should be involved at all stages of planning. And data must be both shared by collaborating agencies and regularly collected and analyzed to assess the efficacy of programs and monitor for any unintended outcomes. So we're going to start with what's called Intercept 0, which is community services and crisis response. So Intercept 0 includes community-based mental health services, including crisis response, to avoid, in the first instance, contact with the criminal justice system at all. When an individual experiences mental health crisis, in many communities, the only point of access to immediate treatment is via 911 call to police. Removing criminal justice players in emergency rooms from the front line of crisis response as much as possible is preferable as a way to limit conflict and unintended consequences of law enforcement involvement, and can also provide a significant source of cost savings, which can be reinvested to improve and increase service options. So alternative crisis response interventions include mental health crisis hotlines, community mental health clinics, mobile crisis team, and crisis stabilization or respite centers where individuals can receive immediate support and connections to services in a welcoming, trauma-sensitive environment. Beyond crisis response, community harm reduction services such as syringe exchanges are critical to addressing co-occurring substance use disorders and mental illnesses. So there's a number of examples. I'm not going to go through all of them, but there's been a number of programs implemented in more urban areas on the mainland that have been very successful. A number of them involve alternatives to 911 for people experiencing mental health crisis, where community members can call a mental health worker and have them respond as opposed to having police respond. So nothing against police officers, they do a wonderful job of de-escalating situations, but I'm sure that they also would prefer to have an alternative option than having to deal with folks who are in a mental health crisis. So the next intercept is at law enforcement response. So this refers to actual police getting involved and responding to individuals experiencing mental health crisis prior to being booked at what would be the Kauai Police Department's cell block. In mental health crisis situations where a law enforcement response is deemed necessary, training of responders and early diversion opportunities are key to avoiding escalation of the situation and reducing arrests. Interventions at this intercept include the crisis intervention team model. I know we have at least a couple officers who are trained in crisis intervention in that crisis intervention team model, law enforcement assisted diversion, multidisciplinary teams, and other opportunities for law enforcement to efficiently connect individuals to treatment in lieu of arrest, often at an access point like a crisis stabilization center. So the crisis intervention team model is actually based on a program that was developed in 1988, so it's been around a long time, and it's been effective when utilized in various areas. One example is in San Antonio, all the police officers are required to undergo 40 hours of crisis intervention team training. It would be great if we also expanded our crisis intervention team training in our departments throughout the county. And then the second intercept is at arrest, booking, initial detention, and first appearance hearings. So this refers to the initial period of arrest, booking, and preliminary court appearances. One of the best tools that we can utilize at this point is the use of a validated risk assessment. It's a critical tool for all prosecutors to identify individuals best served by diversion and alternative to incarceration programs. And although it seems somewhat counterintuitive, interventions are most effective when focused on high-risk populations. And intensive interventions can actually increase the risk of reoffending when applied to lower risk populations. An accurate risk assessment is critical to avoid adverse outcomes as well as make efficient use of scarce resources. So prompt and accurate screening for behavioral health needs and connection to services at the point of booking and arraignment can create early exit ramps from the criminal justice system, as well as potentially improve health outcomes such as overdose-related fatalities. Other interventions at this intercept include pretrial diversion, charging guidelines that recognize the role of mental health conditions, and bail policies that prioritize access to treatment in the community and avoid the conflation of mental illness and risk. So here are some examples of validated risk assessments that have been used in different places throughout the country. One is a brief 25-question instrument, which both evaluates risk and flags needs such as substance use or mental health issues. It's used in various places throughout the country. In New York City, they have the City Health and Hospitals Division of Correctional Health Services launched an enhanced pre-arraignment screening unit in Manhattan to increase capacity to provide medical care to people moving through the arrest to arraignment process and improve diversion for individuals with mental health needs. In Johnson County, Kansas, one really interesting program they have is they are able to include data for mental health co-responder programs in their JIMS, their Justice Information Management System. That's something we regularly use in our office to keep track of case tracking data. So including that, those mental health co-responder programs is an innovative way to make sure that there's follow-up and continuing care. So intercept 3 is jail and court. So this refers to pretrial detention, so that would be either at the cell block, Kauai Police Department cell block, or at the Kauai Community Correctional Center in Wailua, the jail, and court appearances from the point of bail to sentencing. Interventions at this point include diversion models like long-term treatment courts. Most folks here are probably familiar with drug court. A lot of places throughout the country have also made use of what's called a mental health court. We also have a veterans court here on Kauai now, as well as another intercept is required psychiatric treatment in correctional settings, in-reach programs at jails and prisons, and improved training for correctional officers, court staff, and for prosecutors as well. Over 300 jurisdictions across the United States now have mental health courts, and numerous models exist. Generally, if they follow risks, needs, responsivity principles, mental health courts are an effective means of lowering rates of recidivism and to reducing time spent incarcerated. And again, there's a number of examples of highly successful mental health courts throughout the country that have been implemented. I'm hopeful that we will also be able to implement one here on Kauai in the near future. We previously had one called the Jail Diversion Program, and we're hoping to get that restarted in the near future. The fourth intercept we have is reentry. And this is the point of reentry into the community after incarceration. Smooth transitions among treatment providers without gaps or waiting periods are a critical concern at the time of reentry. As a prosecutor, we can be powerful advocates for improving those reentry services, such as programs which emphasize a continuity of care from jail-based services to community-based services, connections to Medicaid and Medicare, peer navigators to create recovery-oriented circles of support and offer models of recovery, housing first programs, and initiatives that improve access to employment. And again, here's some examples of some evidence-based programs throughout the country that have been used. In Chicago, the jail aims to promote a smooth reentry into the community via its Mental Health Transition Center, which creates a community support system for individuals with substance use and or mental health disorders through mental health and substance use treatment, educational opportunities, and vocational training and assistance. A sheriff's department van staffed with a mental health professional is available to perform mental health checks on former clients of the program and provide transportation to treatment. Cook County Jail is also home to a unique program that permits individuals to apply for Medicaid and be connected to psychiatric services while incarcerated. They also are supplemented by what's called the SRC, or the Supportive Release Center, which gives formerly incarcerated individuals identified as high risk a safe place to sleep, have a meal, wash clothes, and make phone calls on the night of their release. This SRC connects people to the services they need to stay out of jail, including an on-site nurse and caseworker who can order prescription refills, make follow-up appointments at community clinics, and provide referrals to service providers for housing assistance and mental health counseling. And then finally, the last one is community corrections. So this is probation and parole. One of the things that we're able to do as prosecutors is avoid excessively lengthy probation sentences. Although it may seem counterintuitive, excessively lengthy probation sentences actually set people up for failure a lot of the time. And so we need to keep that in mind. And Hawaii has the longest average probation length of any state in the nation. It's over 4 years. So that's problematic for folks who are trying to get their lives together, because it's just another hurdle that often they have to overcome that sets them up for failure, not success. So prosecutors and probation parole officers need to be cautious to not conflate mental illness with an increased risk of reoffending, and thus impose more conditions on individuals with mental illness. Specialized probation for individuals with mental illness is also a promising practice in which designated probation officers have specialized training in mental illness and lower caseloads in order to accommodate the higher needs of individuals with mental illness on probation. Research indicates that community supervision services specifically designed for individuals with mental illness decrease rates of reincarceration. So there's a number of, again, examples of places throughout the country where they've implemented programs like this, where there's mental health probation specific officers, and where those have been successful. Notably in Multnomah County in Portland, and they also have a mental health court in Texas, where they have a voluntary program of supervised probation. So I want to talk a little bit about what our office is specifically doing at each of these at various intervention points, and how those are connected to what I talked about in the overview of those intervention points, and how we're hoping to expand those. So the Intercept 2 was the pre-charge and at arrest. So we've just entered into a partnership with Ho'ololahui to identify individuals pre-charge in need of mental health services. So our plan is to have a social worker from Ho'ola respond to KPD cell block on a daily or as-needed basis, and conduct a needs assessment with the folks in cell block, and see if the individual will commit to follow-up care with them upon release. So we're still in the planning phases of that, but we just secured a grant through the Vera Institute to start that program. So for folks who aren't aware of the process, what happens is once a person gets arrested, they're brought to the Kauai Police Department cell block, which is a limited resource location. So it's just a place to kind of house people until they're brought to court, and then they're taken to the jail. So our hope is to intervene earlier so that they're not spending a lot of time in the jail before they get into more problems. And Ho'ola has those resources because they're already helping a lot of folks who are further down the path. So our hope is to intervene a little bit earlier to help those folks. And we're hoping to start that in September of this year. So Intercept 3, we're really fortunate that on Kauai we have a medically assisted treatment program at our jail, and we are doing everything we can at our office to support that program. For those of you who aren't familiar with medically assisted treatment program, what is involved is medications such as buprenorphine, also known as Suboxone and Sublocade, reduce the risk of death from drug overdose for offenders released from incarceration, especially the first few weeks after their release. This program helps patients from overdosing upon release from detention. The County of Kauai has become one of 30 states that have enacted some form of medication-assisted treatment for inmates. And since, I have this data from an older article, but since 2021, 101 inmates have received medication to treat their disorder or addiction. And addicts take a dose that's high enough to blunt symptoms of withdrawal, but too low to produce a feeling of euphoria. So how we assist with that program is we're often contacted by the nurse at the jail, and we try to work together to find out if an inmate is going to be released and communicate so that that person can have continuing care upon release. And we try to have them released from the jail rather than at court so that there can be follow-up appointments made and continuing care for folks who are in that program. So that's a wonderful program. If you're interested in learning more, you can talk to Dr. Chilius about it. He's the resident expert and the one who made that program happen at our jail. Intercept 4 at reentry. This last year, we started a GO-PAC program, and that was with the Kauai Rural Health Association. So there was a survey done, and we identified various needs of the Kauai Rural Health Association conducted a survey at the jail, I believe, and the various needs were identified, including transportation, access to resources, applying for insurance. So what happens now is that when folks are released from incarceration, they're provided a pack of information that has these resources in it, including bus passes. There's 2 doses of naloxone, brochures with resources for employment, housing, medical insurance, information on how to obtain an ID, and a feedback form to anonymously comment on the quality of the packs. So we're hoping to expand access to that. We also just applied for a grant. This was on our, it was on the council agenda last week from the Bureau of Justice Assistance for $1 million through the Second Chance Act Pay for Success program, which would allow us to expand our reentry services and our GO-PAC program. So the name of that program that we're hoping to establish is called E Ho'i'i Kapiko, which roughly translated from the Hawaiian language means a return to center. It would allow us to hire a full-time staff member to work solely on coordinating reentry services and establish office space outside the prosecuting attorney's office. So our hope is to be able to establish that later this year if we get the grant funding for that. So those are the programs that we're currently working on and at the various intervention points. Oh, I meant to click that. So that's my presentation. Does anybody have any questions? Yes, Regina. Absolutely. So her question, for those of you who didn't hear, was why is having a lengthy term of probation a bad thing? And so, because she was talking about how I said Hawaii has the longest length of probation. So a lot of times probation can be, evidence has suggested that it leads to more contacts with the criminal justice system. So there's been evidence that there should just be sanctions for serious probation violations. So if we keep people who, for example, may have a minor relapse, or relapse is seen as a step in recovery. So if they have one relapse and they end up going back to jail, that can really compromise their housing, compromise their job, compromise their relationship with their family. So it would be most beneficial for them to be have contact with mental health resources in the community rather than having to report for a lengthy period of time after their case. For example, there's some cases pending in our office for lower level offenses that happened 8 to 10 years ago that they're still in this probation cycle. So it's so disconnected from when the offense actually took place that it often doesn't set those folks up for success in the community. Does that answer your question, or did you have? Okay, go ahead.
I have a microphone for you. Here you go.
I was just wondering, okay, do the people that the mental health would help them more than probation? That's what I heard you say.
Yes.
So do a lot of those people really percentage-wise seek mental health versus somebody that is being overseen by the government and you know where they are versus they're wandering the streets? So I'm just wondering.
That's a great point. So as I kind of started out my spiel, I think it's important for us to take advantage of these various points to try to kind of push people into mental health treatment. But at some point, it's just not going to be 8 to 10 years after an offense has taken place. It's often not beneficial for that person if they're not already engaged in some sort of community-based treatment.
I think my question was more based to the people that should seek mental health. Do they really go? I mean, is there any kind of statistics about that? That show that, I understand, I think it's a good thing to seek mental health, that's great. But I'm just wondering if there's any statistics that support that they actually go to seek mental health services. And I would think not, but I wanted to hear from someone who actually deals with this population.
I think that's probably true, that most folks don't seek them voluntarily. So that my hope is that we can incentivize it at these various points in the process. So for example, if we're able to provide access to resources at cell block through Ho'ola, we'll take that into consideration in the disposition of the case if they're willing to get follow-up services. Or the same thing if they complete drug court or mental health court, then their case gets dismissed, or they get there's some sort of acknowledgement that they've sought those follow-up services.
If I may also respond to that. So currently, not every time, but sometimes people with severe mental illness are released from our jail in a pair of paper pants, and they walk down the highway with no plan, no medicine, nothing. And this is not ideal, okay? And so does that person end up seeking mental health care? Probably not, And so, I think it's important that we understand where we are right now. We absolutely have a crisis of mental health care access on this island right now. And where it's most acute, from my perspective, is those people who are being discharged from our inpatient unit at Maholona and those people who are being released from KCCC. And I was just talking with Dr. Young, as far as I am aware, we are currently recruiting for 7 psychiatrists on this island right now. It is very difficult for us to have a follow-up plan for people who are being released from these acute environments where they can follow up with a psychiatrist or other prescriber within 7 days. They can see a therapist quickly, whatnot. So I believe that the prosecutor's office, myself, and other organizations in the community are trying very quickly to build the infrastructure necessary to deal with this. For example, we are about to hire, as Prosecutor Like noted, an in-reach person, somebody whose job is literally to reach into these facilities from an outside agency and to make sure that we are coordinating their release. People who do not have a good reentry plan, whether they have a substance use disorder or a severe mental illness, generally do not do well. And because these people are not well, to expect them to just walk down the street in their paper pants and just show up at somebody's office, many times months later when the appointment comes around, that's just not a workable solution. So, I was so pleased with your presentation today. I think this dovetails well with what other people are working with. So,
Thank you.
Let's give him a round of applause. Thank you so much for sharing.
There's one
that.
other question.
And we have a question over here. Thank you. Hi.
Hi, aloha everybody. My name is actually Dr. Kahana Kuikahi Duncan, and I'm from Ho'ololahui, Hawaii. So I did want to speak a little bit on the program that we are trying to do. The idea is that if we can target and do like a warm handoff, right? Like Dr. Chilius just said, they're not going to seek support by themselves independently. So the idea is, because we're spending so much money housing our inmates and providing care for them, we're trying to see if there's a better way. So the idea is that we will go into cell block, make that connection with them, and hopefully set them up with different resources, be it health insurance, housing. At Ho'ololahui, Hawaii, we are essentially built to be a one-stop shop. So we have medical support, dental, we have behavioral health, a pharmacy, as well as case managers and community support workers who are going out, who are meeting people, who are really trying to find those who are needing more support. So just to kind of, support Prosecutor Leakey, we are really trying to approach a different stance where we can look at it more as collaboration versus just expecting the inmates, like, okay, you're out of jail now, so go figure it out. So we're really trying to practice that warm handoff and provide more support for them to re-entry into our communities.
Thank you.
Thank you very much. That was really a great presentation. I'm Jerry Young. I'm the HPH Medical Group, Kauai Medical Director, and I just wanted to tell you how important the issue of substance use disorder is in this community and our country as a whole. In terms of forcing people into treatment, I wanted to share that I sit on the board of Pu'ulapa'au, which is the Hawaii Program for Healthcare Professionals, which is an offshoot of the Hawaii Medical Association's Old Physicians Health Committee. This nonprofit is dedicated to making sure that healthcare professionals, both physicians, nurses, advanced care, advanced practice providers, such as PAs and APRNs, are given the opportunity to keep their licensure if they are diagnosed with substance use disorder or dual diagnoses. These are not just diseases of other people. We ourselves sitting in this room are at much risk for these kinds of things as our patients. And so that is I just wanted to share that because I think it's really important. And this program that we have in our state is present at many of the other states in our country. I am vice chair of this board, and I'm happy to talk to anybody who has questions. In addition, I sit on the board of medical examiners, as well as Dr. Fujimoto, and we are, really a big thing is enabling our healthcare professionals to maintain their licensure once they've get treatment for their medical issues. Thank you.
Thank you.
I have a comment from Representative Nadine Nakamura.
Thank you, Rebecca, for that great presentation. It's really wonderful to hear our prosecuting attorney get involved so deeply in this important issue. I just wanted to mention that and for Graham Chelias for his work as well. One of the bills that I introduced this session that passed through the legislature is to provide supportive housing for people with mental health issues, substance abuse issues, children aging out of foster care, people who are coming out of prison, people who with developmental, intellectual, physical disabilities. These are, we need to do specialized housing for these groups of people with not just building the house, but providing rent relief because incomes are so low, and also the wraparound supportive services. So the pilot program that I introduced, and hopefully the governor will sign the bill, will produce hopefully some housing. And I really encourage those of you who work with reentry to try to identify potential sites, and so that we can try to figure out how we can provide some long-term resources to make this a possibility on Kauai, and then to make sure that it can be sustainable over the long run. So I encourage this further discussion, and hopefully we can work with James Koshiba, our new Homelessness and Housing Solutions appointee, to carry something out on Kauai. Thank you.
Thank you.
Hi, thank you for your service to the community. I'm curious, what is being done before somebody gets incarcerated to identify people who have mental wellness issues or drug addictions, whatnot? that, are falling through the cracks before they even commit a crime. What's being done to identify those people and offer them some support?
That's a good question. It's very challenging to intervene and identify those folks from our end before they come into the system. So that would be probably a better question for like a medical provider. So I know that personally, when I go to the doctor, I get more screenings for depression or substance use issues, but we don't have a lot of contact with folks who are outside the criminal justice system. So usually our first interaction is when we find out that somebody's been arrested, and then they're down in cell block, because cell block is right underneath my office, but that's usually our first contact with folks. So it's a good question to ask, how can we identify people at an earlier stage? So some of the programs that I mentioned in my presentation in more urban areas, they have community-based programs where people can either check in on their own, or the police department, when making an arrest, if they're able to say, oh, this person is clearly suffering from some sort of mental health crisis and is in need of some sort of intervention, not necessarily hospitalization at an ER, but needs something, they can take them to these centers where they can get mental health or drug treatment. We're not there yet, but I think we're moving in that direction, hopefully with the expansion of the Mahilona campus and with programs like Representative Nakamura was talking about. So.
And thank you. Just for a follow-up, and what about because it seems like they might be kind of more in your realm, what about the homeless?
It's kind of the same issue, sort of. So, I mean, the homeless, oftentimes, they're getting picked up or swept up for offenses like trespassing, disorderly conduct, harassment, theft, offenses like that. So our hope is that if we're getting those folks, that with this new program that we have with Ho'ola, we can get them in touch with some services to catch them earlier on before those problems continue to escalate and become worse. So that's our hope. Yep.
Any other questions? Thank you so much. Let's give Rebecca Like a round of applause. Thank you for all of the work that you do, all of the prosecuting attorneys.
So we are going to bring up our next speaker, Dr. Janet Berriman. This presentation will explore how upstream factors affect both mental and physical health and the role of primary prevention in improving overall well-being in our community. Dr. Janet Berriman is the Kauai District Health Officer for the Hawaii Department of Health, and she is trained as a pediatrician at UCF and practiced pediatrics in American Samoa before joining the Waianae Coast Comprehensive Health Center as one of their first pediatricians. After more than 15 years of clinical practice, Dr. Berriman transitioned to the public health. She completed a Master of Public Health at UC Berkeley and served as the City of Berkeley's health officer for 10 years before returning to Hawaii in 2017. Health equity and developing future generations of public health professionals are integral parts of Dr. Berriman's work. The Kauai District Health Officer is a perfect position to bring together her experience in rural, Pacific Island primary care and local public health, and her commitment to equity and workforce development. Let's give a big round of applause while we welcome Dr. Janet Berriman.
Thank you very much. It's such a pleasure to be here. It's nice to see faces I haven't seen for a while, and it's nice to see people in person. It wouldn't be a talk from Dr. B if I didn't say something about COVID, so I will say that it's really nice to be in this room and not be doing COVID testing or COVID vaccinating, either for other people or for myself. So really a pleasure to be here. I feel I had a little bit of trepidation about doing this talk, and especially following the talk we just heard and the conversation about it. I hope this doesn't sound simplistic or simple-minded, and I want to be clear that I don't in any way think that primary prevention and the upstream things I'm going to talk about are a substitute for care and treatment and more downstream direct clinical service. But I would challenge us all to be thinking across the entire spectrum of what creates things, people and situations that require treatment, and what portions of that might we be able to prevent. So I hope that you'll keep that in mind. I use a lot of pictures, which is good because you won't be able to see any of the writing on my slides, but I like to use the DOH logo, and as I was looking at this one, I thought it's particularly nice for today's talk because it shows the person in the middle really being an integral part of their environment. And that's what I'm going to talk about, is the environment that nurtures us and creates well-being. I also hope that in that logo, the intent is that the head is connected to the body, although I see that actually it's not in the logo, so maybe we need to do a little bit of redesign there. I also wanted to say that in my journey from primary care pediatrics to public health, it's really changed the way I think about the kinds of problems and issues that I used to see in my pediatric office and treat in my pediatric office, and has led me to ask, why are these conditions here? What's contributing to that? And are there things that we could be doing as a community, not just as a healthcare system, to lessen the level of disease and illness in our community, in our population? And I think we can and should ask those same questions on the mental health side, because I really do believe that the mind and the body are connected, and I hope that you will understand a little more what I mean by that as we get through this talk. So has anybody, raise your hand if you've heard of the Children of Kauai longitudinal study. Okay, good. I'm glad that several people have. I had not before I took this job, and when I learned about it, I was really kind of embarrassed that I didn't know about it. So these two researchers, Ruth Smith and Emmy Werner, followed every baby born on the island of Kauai from 1955 for 40 years, from the year they were born until the year they turned 40. Of course, some of them dropped out in the meantime, or they lost track of them, but it was a long-term longitudinal study looking at how did these children fare, what was in their environment, and what characteristics were there for those who were more resilient, more successful in life, if you will, especially if they came from very challenging backgrounds. So tiny little Kauai, Dr. Fujimoto said to me earlier that during the pandemic it felt like we were way out in the middle of nowhere. Tiny little Kauai is really one of the original places where the work identifying protective factors in youth and youth resilience was first identified academically and shared. And that's really part of the basis for the Kauai Resilience Project and the other work that we do here. So as with COVID, Kauai should feel proud that we're small but mighty and we do really good work here. And the books are all in the library. And I checked them out and read them. So I'm going to, I know you can't read this. I'm going to have three main parts to the talk today. I'm going to talk about what I mean by what a public health perspective is. I'm going to talk a little bit about what it means to say that health is well-being overall. And I'm going to talk about what some of the things are that you can see and hear and do in Kauai that promote community well-being. And then I will summarize and answer your questions. And I have notes on my paper, so I'm multitasking here. Did I? There we go. So what is public health? Well, I think about public health in contrast to the clinical medicine that I did before. So public health really focuses on the community. It strives for prevention as the ultimate goal, recognizing that we can't prevent all ill health, but working on really, that's where the public health main focus is. We also hope to achieve equity in health, and we hope to build on people's assets. And I think that that's something that public health actually is challenged to do. We do a lot of identifying populations who are at risk and who have problems and who suffer from health inequities. And that narrative about things are not good for you and your people in your community can be very disheartening. And so the effort to work on what are the strengths in all of our communities, because we all have them, and how can we build on those and frame our discussions more positively is something that I think it's really important that we do in public health, and it's an area where we're still working on. So I'm going to look at each of those a little bit more closely. So this is from the Department of Health's website, and this is talking about our responsibility as public health to serve the community. And you can see that it says in our mission statement that we serve all people in Hawaii. And lots of people talk about population health and community health these days, but often population means our constituents, our clients, our insured people, our enrolled students, citizens, legal residents, employees, whatever it is, there's often the population is limited in some way. The population that public health is responsible for is also limited, but it's everybody who's here in Hawaii. So during the pandemic, that included tourists, that included everybody who was physically here, we had a responsibility for. And we do every day for public health. It's our responsibility to make sure that you don't get sick from the water or the food, whether you live here or are visiting or are newly arrived here. Let's see. So I wanted to talk about prevention, and I have a lot of miscellaneous thoughts about prevention, because I said public health really focuses on prevention. And physicians can do a training in preventive medicine. They can do a preventive medicine residency. I don't know if anybody here might have done that. And it's still very clinical focused, but it focuses on prevention. And people use the term prevention in many different ways. So one of the things in public health that I think is helpful is to think about levels of prevention. We talk about primary prevention, secondary prevention, and tertiary prevention. So maybe this is where the hard question is going to come from, I don't know. Primary prevention means preventing the bad thing from happening at all. Secondary prevention, and this is simplified a little bit, but secondary prevention is screening and identifying the bad thing so that you catch it early and you can take care of it before it gets to be a big problem. And tertiary prevention means you got the big problem, but we're going to try to minimize the complications and make it as easy for you to live with that comfortably as possible. And so I wanted to walk through a couple of examples, because one thing I always say is, well, would you rather have cancer detected early, or would you rather not get cancer at all? Most of us would rather not get cancer at all, right? Gotta laugh. So if we think about diabetes, especially type 2 diabetes, primary prevention is really things like ensuring that the environment is such that children from the time they're very, very young have healthy eating habits and active lifestyles and never have anything in their environment or never have their environment as a whole putting them at increased risk for diabetes, recognizing that they may have genetic or other predispositions to diabetes. So that's never going to prevent 100% of diabetes, but it can prevent diabetes on a population basis in a significant number of people in the population. Secondary prevention of diabetes is doing the blood test screening. It's called a hemoglobin A1C, identifying pre-diabetes, which is still moving in that direction, intervening at that point, managing your diabetes early so that it doesn't get worse, maybe doing weight loss and exercise and those sorts of things. The clinicians in the room can tell us more about that. And then tertiary prevention in diabetes is you're on your diabetes medicine, but we're making sure that you're coming in to see the doctor, using your medicine regularly, using it in the right doses so that you don't suffer complications like neurologic problems, amputations, all those kinds of things. That's one example. I'm going to walk through a second example, which is childhood lead poisoning. So I'm a pediatrician. We do a lot of testing kids for lead when they're about a year old. And if the lead level is elevated, then we send our public health nurses out to their house and we try to figure out where the lead is coming from and we remove that source of lead from their environment. So what level of prevention is that? Primary, secondary, or tertiary? We test them, we see it's elevated, we take away the source. Secondary, very good. Okay, I already asked the hard question. So primary prevention is when we in the health department are testing the lead level in water in all of our schools and making sure that there's no lead in the water. It's making sure that there's not lead in foods. It's making sure that there's not lead in gasoline. When I was a kid, there was lead in gasoline. And my generation, the average lead level in our blood when we were children is a level that we would identify as being toxic now. So I would have had some more IQ points if I hadn't grown up when I did, but oh well. And then tertiary prevention is you have a child who's already been lead poisoned. Their lead level has been very high. We know that that causes irreversible neurological damage. But what we can do with those children is put them in early intervention programs, special education programs, promote their development and well-being as much as we can, even though they already have the bad thing has happened to them. So in all of healthcare, we talk about prevention and we talk about anticipatory guidance, and we work across that spectrum. And on the clinical side, we tend to work more on the secondary and tertiary prevention, and on the public health side, we tend to work more or strive to work more on the primary prevention side. It doesn't mean we don't do all of it, but we really are focusing on that in a way that healthcare doesn't normally do that. And I said before that even primary prevention isn't going to prevent everything, right? If you think about it in terms of mental health, we're not going to prevent all mental health disease. We're not going to prevent all diabetes. We're not going to prevent all lead poisoning. But by acting at that level of primary prevention, we can decrease the number of people who wind up needing care further downstream, as we say, and free up our very limited resources to provide that care. So the primary prevention actually helps us do the treatment and the more downstream work, and I'm slightly getting ahead of myself. Questions about the prevention piece before I go on? Okay. I'm sorry, you really aren't going to be able to see this, but if you want to see the slides, this is a graphic from an organization called the Bay Area Regional Health Inequities Initiative, or BARHI. And it's actually a group that I was part of many years ago, and it started as a very neat line with 5 points along it, and it's become this very complicated graphic. But it's talking about what it means to act upstream or to address root causes of health problems or health issues in our communities. And that can be mental health issues or physical health issues or a combination of those. And downstream is to the right on the picture and upstream is to the left. And downstream is things like hospitals and emergency rooms and clinics and medications. And in the middle are things, well, and then as you move a little bit upstream, you see risk behaviors. So somebody's not eating healthily, or somebody's drinking too much, or somebody's using substances, or somebody's doing other risky activities. One of the things we can one of the ways we can make sure that we're looking at upstream interventions or root causes is to ask ourselves why. So why is that person eating an unhealthy diet? Why is that teenager drinking or using drugs? And if we say, well, you know, that's the only kind of food they can buy in their environment, or they don't have anything else to do after school, that leads us to think about living conditions and what's around that child or adolescent. What do they have access to? And then if that's all they have access to, we can ask ourselves, well, why is that the case? Because that's not true for every young person in our island. And if you keep asking why, you move further and further left toward root causes and upstream causes of health conditions. We also talk a lot about health equity in public health and other places. Over the last 15 or 20 years, I think it's become a much more common part of the conversation than it was when I first started in public health. And sometimes when we think about equity, we think, well, that means doing the same thing for everybody, which is actually what equality is, right? If I just make it equal, every single person gets the same thing. Equity really means providing for people what they need to bring them to a similar level as other people. And that's what this graphic, which I don't know if you can see from where you're sitting. So the first one on the left, equality, everybody gets to stand on a little step that's about 1 foot tall. But if you're in the wheelchair or you're short, you still can't see over the fence. So it's equal, but it doesn't result in equity. In the second picture, there's a ramp and the heights of the steps are related to the needs of the people so that everybody can see over the fence. And then this graphic takes it a couple steps further and talks about justice and inclusion, where you actually take down the fence, you remove barriers to resources, and then you ensure that everybody has an equal opportunity to participate. I think that we should be thinking about and striving toward all of those things, and equity is the first step. How many people here are familiar with ACEs? adverse childhood events. Okay. I feel like we talk about those a lot in our community, and particularly in our mental health community. How many people are familiar with positive childhood experiences, PCEs? I see a couple. I have to say that I had never heard of that as a thing. I'd heard about protective factors, but looking at what happens to children and youth that are positive experiences that are predictive of their success in future life. And remember when I was talking about looking at assets versus deficits? This is a really good example to me, because if you're the parent and I say to you as the pediatrician, your child has 7 adverse childhood experiences, and any more than 4 means they're going to have a hard time in life. And we can't change any of those things that happened in the past, because those are the adverse experiences, they're there. So we have to figure out what we can do to make this bad situation not quite so bad. As a parent, if I hear that, I feel like, darn, I've done a bad job, or I haven't protected my child, or my child is doomed. It's not a very positive feeling situation. In contrast, and of course I'm using different tone of voice and making you think what I think, but if I as the pediatrician say, you and your family and kids have been through a lot, and when I hear what your child has been through over the last 6, 8, 10 years of their life, I see these 3 positive experiences that your child has had. And I think we can look at some other potential positive experiences that we can add to your child's life that will help your child be even, stronger, more successful, better able to do what they want to do in their life. Let's look at some of these other opportunities and see what we can add to the positive foundation that your child already has, even in the face of adversity. That's what I mean by an assets-based or a positive strengths-based intervention. And it's a different conversation in a community. It doesn't say, you have all these things against you and it's really bad and we're going to have to move forward. It says, there's some real strong strengths here. How can we make those bigger and greater? So I think that positive childhood experiences, and I've also seen them called BCEs. I can't remember what the B was now. But I think that for all of us who talk and think about ACEs a lot, I think it will behoove us to think about how we incorporate positive experiences into that also and really make that part of our focus. Okay, so what does well-being mean? Well, again, this is from the Department of Health's webpage, and it says that health is an optimal state of physical, mental, social, and environmental well-being. So it's the whole package. It doesn't say just the head floating up there, or just the body, or just the environment. It's the whole package. And that's what we mean by health is well-being. Has anybody heard of weathering or the weathering hypothesis? So the woman who came up with this hypothesis in the early 90s is named, Geronimus is her last name, I can't remember her first name, it starts with an A. She just wrote a book about her research called Weathering, which I just read. It's in the Hawaii State Library. I highly recommend it. But she also has a lot of academic publications over the last 30 years. And the weathering, when she says weathering, she's saying that the kinds of stress that are in marginalized people's lives, and they're in this graphic: racism, poverty, alienation, marginalization, structural inequalities, lack of culturally appropriate services, all of these things, chronic exposure to socioeconomic disadvantage, marginalization, and discrimination leads to early health deterioration. And that early health deterioration is not limited to physical health, and it's not limited to mental health. And the term weathering refers to, like, if you have a wooden chair and you leave it outside where it's exposed to the weather and it weathers, what happens to the wooden chair outside? It gets faded, the finish peels, it starts splintering, it starts falling apart. As opposed to if you have an identical wooden chair that you keep inside where it's drier, it doesn't get the sun shining on it, it's going to last a lot longer. So people exposed to that impact of the weathering of all of these kinds of things experience ill health sooner, and they die younger than people who are in a more supportive and positive environment. And the net result is that when we talk about health inequities and differences in life expectancy across different groups and in different communities, I think it's really important that we understand that not only is life expectancy shorter in some communities, in some places the differences are measured in decades, not just in years, but those shorter lives are less healthy lives as well. So it's not just that you're going to die when you're 60 instead of 80, but you're going to more likely to be chronically ill or in poor health from the time you're 35 or 40 until that early death. So it's a big, the equity piece is not just about how long you live, but how well you live. So that last slide talked about what some of those sources of stress are. And they're not like, oh my goodness, I have a deadline or I have to give a talk today and that makes me stressed. They're really the fundamental stresses in life of, can I pay my bills? Do I have a place to live? Can I get food for myself and my family? Is my environment toxic with poisons or with violence or anything else? And that has physical effects of what I just said early, and these are all data-driven things. I'm not citing you the data, but they're in this literature. Early onset of chronic disease, shortened life expectancy, poor birth outcomes, and on the mental and emotional side, increased rates of depression and suicidality and substance use and abuse and intimate partner violence. So it really has an impact on all of these things. So what does public health do about this? We fix it all, right? I wish, in my dreams. But it means that when we're thinking about primary prevention of all of these stressful things, public health at least tries to influence things that are far outside of what we think of as health or health care. So trying to influence things like housing security, somebody asked about homelessness earlier, food security, satisfying employment, a living wage, being able to work just one job and make enough to make ends meet, which is something that we have not achieved on Kauai for most people. Education that's available and accessible for everybody in a way that's meaningful and constructive. And then we also look at things that are more on the secondary prevention side that mitigate the impact of stressful environments. Things like ensuring that people have places to be active, to be outdoors, a sense of belonging with others, multi-generational connections, and connection with a trusted adult. And many of those are things that were identified in that study that I mentioned at the beginning, Children of Kauai. And from here, I'm just going to show you some pictures. All of these are Kauai pictures. You will probably know what some of these events are that I had to look up on the internet. But when you look at these things, I'd like you to look at them not just as like, oh yeah, that's a nice thing that we have here, that we do here, but that this is integral to how we protect the health and well-being of our community. And building on these opportunities is what's going to continue to make this a place that people can and want to live, and that our children and young people and youth and young adults also can and want to live and can stay. So being active together is good for your physical health and your mental health. Being outdoors, some of you may recognize the skate park, at least the child is wearing a helmet. I'm not sure skate parks are always good for your health. Paddling on teams with peers. Let's see. These are some connections across generations, the shared family meals, the safe play streets. And the picture on the left at the bottom is a fair that actually happened here that was cross-generational that I didn't write down the name of, and it was before I was here and I don't remember what it was. And then our parks, the Path, the Kalena Park that's been renovated, the work at Laukona Park. Anytime you see our county or our Parks and Recreation or other people improving these kinds of assets in our neighborhood, I think it's important to remember that not only does that support physical health through activity, but it supports mental health through being outdoors, through socializing with people, through getting and having something to do other than be online or use substances or whatever else we're doing. Employment, we have an employment piece to this conference today. Thank you very much. And I think working toward what are the opportunities for meaningful employment and long-term employment here on our island is really, really important. These are just some brochures I downloaded. I want to make a plug. The Department of Health has 120 jobs on Kauai, and we have about a 20% vacancy. And those range from everything from clerical work to IT work to nurses and doctors and epidemiologists and educators and all kinds of things, lab technicians, people who test the water. So anybody who's interested in a public health career, let me know. Safe, secure, and affordable housing is, I think, one of the very hardest nuts for us to crack here on Kauai. I don't have to tell you that it's hard to find an affordable place to live. And then affordable food that's healthy. It tends to be that the food that's most affordable is also fast food and not as healthy for us as it could be. But we do have programs such as WIC and DeBucks that discount healthy food for our low-income residents, food banks and food pantries, educational experiences for all. This is a middle school art show that happened a while back. And educational, I mean, it's a big deal to graduate even from kindergarten or from KCC, and then the virtual graduation that we had for high school during COVID is on the bottom right there. So that's the end of my fun pictures. I just wanted to sum up. We talked about public health being community-based, focusing on prevention, promoting equity, and being assets-based. And I just want us to remember when we see the problems and are trying to address the problems downstream, while we do that downstream providing treatment and care, that we also be thinking about, also ask ourselves, what happened that led to this? And are there things that we could be doing upstream to prevent it from happening to the next person or again to this person? So I lied, I have a healthy ocean, supports a healthy community. Thank you very much. Did I talk too long? Okay. Yes, Graham. So Dr. Chelios is asking about our suicide rate on a population basis here on Kauai. And I know that at least intermittently that has been the case, that we have a high suicide rate for our population. It's actually, from an epidemiologic data perspective, a rather challenging thing to know for sure, because those, oddly enough, data about suicide are not collected in a way that's really consistent and really inclusive. And we have a very small population. And so very small changes in numbers can give very large changes in rates, and it can be hard to tell. So I would say guardedly, yes. I think every once in a while we see a year that is an aberration and we don't know if it's how meaningful it is, except obviously it's a tragedy for the individual and their family. Sorry. That's the public health nerd.
From your public health expert perspective, why, if that is the case, why is that?
Well, so this is why I said, really, you want me to talk at this meeting? Because I am not a mental health clinician. But that said, when I talk to people in the community, pre-pandemic and during pandemic, I hear a lot about our young people don't see a future for themselves here. They feel like they have to leave. Families are being separated. People are working 2 and 3 jobs. Multiple members of a household are working 2 and 3 jobs. When you think about how important it is for youth and children to have a close connection to at least one competent, caring adult, lots of children and lots of families are really challenged to meet that just because of the challenges of getting food on the table and keeping a roof over your head. So I think that, to me, what underlies it is these very things that I've been talking about, that we are not, and I think the Resilience Project is on a great path and is doing great work, and I think that's some of the absolutely most important work that's going on in our community. But we have to provide a better sense of optimism and future and potential for our young people here.
Awesome. Any other questions?
Can you give some examples of positive childhood experiences?
Yeah, actually, I had a couple other slides that I took out, but I have them in my secret paper packet here. But they are things like connection with a trusted adult, the ability to have peers and elders that they reach out to for advice and support. Let's see. There's something called the HOPE framework, Healthy Outcomes from Positive Experiences, and the reference for that, my last slide is references. And if you get the, this isn't working for me right now, but if you get the PowerPoint handout, you'll be able to see it. Relationships within the family and with other children and adults through interpersonal activities. Safe, equitable, and stable environments for living, playing, and learning at home and at school. Developing a sense of belonging and connectedness. Playing and interacting with peers for self-awareness and self-regulation. So it's really a lot of connectedness to other people in a variety of different places. And that includes positive connections in the educational realm, so teachers who have high expectations for everyone and don't assume that some children will not be as successful as others, and parents and family members who do the same. And one of the things that the Resilience Project has talked about is that, you know, every young person needs a trusted adult in their life that they can go to. And not everybody's going to find that in a parent or even a grandparent or an auntie. So we can each ask ourselves, if you aren't that person for any young person now, is there a young person in your circle for whom you could be that person? So that's how we can all be part of the solution.
So for like generational substance abuse, sex abuse, child abuse, families, any alternative, like any ideas about alternative experiences?
Yeah, so in my work as a pediatrician, I had a lot of interaction with the child welfare system. And I have, this is personal talk, not Department of Health or anything talk. I have a lot of, and we know this, it's in the literature too, we can do a lot of damage by taking children out of their families, even if those families look to outsiders or objectively look dysfunctional or problematic. But when you think about when I think about a single trusted adult or an elder that those children can go to, I think about how do we connect them through things like Big Brothers Big Sisters or Boys and Girls Club, that sort of thing. Where can children find outside of that multi-generational problematic family somebody that they can have a connection to? And that's what the Children of Kauai study found. There were people who, when they were 17 or 18 in that study, everything seemed to be lined up against them, and they had dropped out of school and they were using substances, or they were pregnant and they were unemployed and they weren't interested in doing anything. And some of those children, when they were 30, were fine, upstanding citizens with families and houses and full-time jobs. And so the question the researchers asked was, what made the difference? And when they looked back in all of their data that they had from all these years, the thing that made the difference the most was having a relationship with at least one trusted adult. It's not rocket science. It still gives me chicken skin to talk about it.
Is there a specific age range that needs to?
I mean, the earlier and longer, the better, but yeah. Was there another hand, or are we?
It was a kind of simple public health intervening in the community in areas that afford building up the resources for the community, for our residents, for our people on the island, and thinking about housing as well. Specifically, like some of the zoning issues prevent us from doing some things. We have shortage of housing, but then the zoning, and then
promoting there are some incentives to actually doing long-term rentals at affordable rentals, but before that and beyond that or after this, to further improve some of the zoning issues that would allow people to actually have that situation, to open up their home to one more a renter or something like that. I think those kinds of things also have to be impacted. And I don't know that it's your realm in public health, but where can we all, I want this group to now, after we have all these questions and talk, go back and send a message to the governor and send a message to the mayor and impact county planning or whatever resources that need to happen to at least get the information that is being discussed here.
I mean, I agree with you 100% and applause. The zoning regulations are at the county level and the Department of Health is at a state level. So but the Department of Health, we're a governmental entity, we're not a lobbying entity. So we can propose legislation and we can educate legislators about legislation that they're deciding about. So there's kind of a fine line between educating people about the impacts of zoning decisions and lobbying for one decision or another. But certainly my role as the district health officer is to provide education about the public health impacts of any kind of policy or legislation that's being proposed at the county level. And I will say that the county council members, Nadine, and our state representatives, Nadine was here earlier, I don't know if she still is, consult with me regularly on a variety of things, and I'm certainly open to that as a resource.
Hi.
Hi.
I really appreciate the work that you do. So here we are, we have like some of the most expensive food, some of the most expensive housing. People got to work 2 jobs, like you said. That leads to typically have more broken families. Suicide rates are high. Homelessness, it's high. Drug addiction, all these things are going on. And I keep hearing examples of these fantastic programs in the mainland. But here we are struggling more than anybody that I can think of. And I know we have stuff going on, don't get me wrong. But where are ours? Where is our prevention? Where is our treatment? Where is the things that keep us from going down these paths that we're on? Thank you.
So, you know, so I've been a local health officer on the mainland as well. And a lot of the programs that I see as fantastic are still fairly downstream programs. They're programs that help struggling families by something called the Family Nurse Partnership, where nurses are involved with families of newborn children. Usually it's a first child. It may have to be a first child, with a very frequent and scripted series of visits over the first 2 years of that child's life. And it's very successful in terms of how those children do in school, how the parents fare in constructive parenting, and all of that. It's extremely labor and resource intensive. Nurses are some of our most expensive, sorry Matt, employees in the health department other than doctors. And it's a very difficult program to take to scale. And if you think about every firstborn child on this island who would benefit from that, that's where I ask the question of why do so many of the firstborn children on our island need that kind of support for parenting? What can we put in place that would change the conditions so that parents are better able to manage that first pregnancy, so that they're connected to other first-time mothers, to the aunties and grandmothers in their family who have the history and the knowledge of how to take care of a new baby. So I'm not sure that programs are necessarily the solution. That doesn't mean we shouldn't have them if we can get them. And I think that part of the reason we have these problems so much more than many other places is that our cost of living, as you said, is just astronomically high, much more so than almost any place on the mainland. And the health department educates our legislators about the benefits of things like guaranteed family leave and subsidized preschool and subsidized preschool teachers and expanding access to child care and a living wage for all. And those are things that public health can educate about, but we can't across the board implement. There's a lot of work and it requires everybody's best input, and I think I'm talking too long.
Hi. I so agree with you that we all need a good environment, especially for our children to grow up in. But one of the things that keeps bothering me, and I know this is a state issue, but it's also a county issue, every month in the newspaper, it says what the bacteria, not the bacteria level, the fecal indicator level is high on our beaches. And every month there are beaches where it's astronomically high. And this has been going on for years.
So it's a complicated question. I'm not sure if you're looking at public health data or other data, because there are other entities that do water testing as well. The health department on Kauai tests ocean water. So we test the salt water in the ocean at the most heavily used beaches. There are other organizations on the island who test the fresh water coming into the ocean water. We do not test that. And those are very different things. Because we know that in the fresh water that's warm and relatively stagnant, these bacteria multiply. So measuring the level in the stagnant fresh water is not necessarily as good a representation of water quality as it is on the mainland because of our ambient temperature. So that's kind of an aside that there's more information in the Clean Water Branch website if you're interested in looking at it. I just had opportunity to review it. Fecal matter doesn't differentiate between human and other. So we know we have a lot of pigs on the island and we have a lot of birds on the island, and they all contribute to that. So it's the testing is to test what's there and let people know when it's safer or less safe to go in the water. But the testing alone, it's not primary prevention, right? It's secondary prevention. It's downstream, so to speak. It's letting us know when it's there. Preventing that is a very complicated problem that I don't have the answer to. Part of it is cesspool conversion and those sorts of things that we know are underway in the state, but that's not the whole issue because it's not just leaky cesspools that are or septic tanks that are contributing to this. So I know that's not a full answer, but it's a complicated problem, and I agree with you that it needs to be addressed. Okay, thank you all so much for all your attention.